Right. Is the voice good? Is it too loud or just okay like this?
It's perfect.
Haha, that's the way we like it.
Okay, in the next few minutes, many people will be joining.
We need a little bit of music while we're waiting in the background. It's very late for you. No, it's relatively late for you.
Yes, it's almost 11.
Okay.
Now we have attendee from different continents, so it's difficult to find a time that fits for everyone. But this one is a
So you don't say
particular.
good morning, you don't say good evening, you say good day.
So most attendee will be from Europe, I believe.
Good.
Hello.
Hi, yes.
Good to
That's
Good
see you.
afternoon for you. Good to see you.
Still on time.
Last minute.
Yeah.
So we're expecting many people to log in the last minute.
Do I have to share my slides, Sanvan, or will you do it?
Now you will have to share your slide once
Okay.
it's your presentation.
Okay.
Okay, it's 5 p.m. CET.
So in total, we have more than 150 registered. So we'll see how many will sort up in time. Maybe some of them will be joining during our presentation.
Well, so far on time, 67 colleagues.
Hmm.
So is Pulse introducing or kicking it off?
I think so. Someone from Post will first.
Okay.
Yeah. Hello, Professor. Can you hear me? Okay, I
Yes.
think there will be more and more people to join the meeting, so maybe we can directly start. Is that okay?
Yeah, we start in time.
Okay. Okay. And good morning, good evening, and good afternoon, everyone. Also, good day. My name is Peng Chengsun from Post Medical, and firstly, welcome to join the webinar AI-based quantification of coronary physiology and plaque vulnerability. And today we are extremely happy to invite Professor William Weiss, Professor Shengxian Tu, and Dr. Joseph Damon, and Dr. Chen Guangli to share their professional experience regarding to the computational physiology and plaque vulnerability. And we're also very glad to have more than 150 people to register the webinar. And I think more and more people will join the meeting now. So I think at the beginning, let's welcome Professor Tu to give an opening speech. Professor Tu, please.
Thank you, Peng. Dear colleague, it's my great pleasure to welcome every one of you attending the webinar organized by Postmedical. So we are gathering together to discuss the AI-powered quantification of coronary physiology and plaque vulnerability. So over the past years, artificial intelligence has revolutionized every corner of our life, including healthcare. So today, in the next 2 hours, we are going to present some of the state-of-the-art technology in quantification of coronary artery disease using artificial intelligence. We will discuss the clinical need for such a solution, methodology and validation, as well as the latest evidence. I hope that you can enjoy the next 2 hours on this webinar. And thank you. Thanks.
Oh, okay, sorry, I'm mute. And thanks for Professor Tu's opening. And let's move on to the first topic. So welcome Professor William Wines to give a presentation with the title of a new one for PCI angiography-based computational physiology, AI and PCI for vulnerability plaque. Professor William White, please.
Workshop.
You can share your screen now.
Q&A with apprentice.
Thank you very much. It's my pleasure to join this team, and I thank Pulse for giving us the opportunity to share basically what I think is very good news. These are my disclosures. I hope you can see the slides properly. Can you?
Yeah.
Great. And so I'm really glad to be on this webinar and happy to share our collective experience with the colleagues on the call, and also happy to address your questions in any form during and also after the webinar. I said good news. Yes, I think angiography-based computational physiology, which belongs to this world of enhancement by AI, is going to give a new wind to PCI. And this new wind will result in improved outcomes for patients. We used to think that we could understand ischemia, both chronic and acute, simply from the coronary angiogram. And we're now realizing that, yes, it is the cornerstone, but it's not enough. And basically, in order to tailor the treatment, we need to understand the causes of ischemia and the symptoms. And yes, we need to have a clear understanding of epicardial coronary artery disease. But at the same time, we want to know how the microvascular function is, particularly if there is high resistance. And we also want to have the ability to recognize vulnerable plaque and perhaps prevent acute events in this way. And the time has come, actually, for this to be reality. Now, in the first few slides, I'm going to tell you how much there is room for improvement in the way we're performing PCI today. First of all, we are over-treating many lesions if we don't perform physiology, and we are under-treating also many lesions who would deserve treatment. And this is taken from a large survey of the published literature, and on average, it's fair to state that the rate of overtreatment is 37%, meaning we are hitting the wrong target with the stent. So this can be improved. As a result, there is lots of interventions that do not reach the goal. The goal is to improve the physiology of the epicardial vessel, which is a conductance vessel that brings oxygen and blood from the aorta to the myocardium. And so if we were to measure, or shall I say compute, the success, the physiological success of an angiographically successful procedure at the end of the case, we will find out that there's many situations, actually not far from 10%, where there still is ischemia. So the patient is sent home with a shake hands, and in fact, we have not even crossed the ischemia threshold with our intervention. And this is not apparent from angiography. Now, this is the worst situation. But there is also situations where we have gained some physiology, but still it's suboptimal. And the data show that, for a procedure to be physiologically successful, not just angiographically, you need to have a post-PCI physiology measurement, either measured or computed, with an FFR or a QFR above 0.9. And you can see here that in about half of the cases, we're sending the patients home with a suboptimal procedure. So this is the room for improvement in terms of treating epicardial disease. Is this a black and white? Is this a specific threshold? No, it's a continuum. This is a large pooled analysis of individual data, and you can look on the left at the rate of target vessel failure, or you can also look at the rate of heart events, later MI, or cardiac death during the follow-up after an angiographically successful PCI. So the vertical axis is the event rate, obviously higher if you compute target vessel failure than if you look only at MI or cardiac death on the right. But still, there is a clear relationship that is steep and still significant for target vessel MI and cardiac death between event rates and the post-PCI FFR. The vertical line is somewhere the point of inflection. But still, we need to understand that it is really important for patient well-being to send them home with a successful post-PCI procedure, having treated a vessel that actually needed it because there was ischemia in the first place. So if people are telling you or asking you what should be the post-PCI result, well, obviously as high as possible, which is above means above 0.9. The point is, and that's the good news, this information that could only be obtained in the past by holding a wire using adenosine can now be obtained from image analysis, image interpretation, and AI-enhanced computational analysis. And so it's not infrequent. As you can see here in the little box, the proportion of patients that are sent home with a shake hands, drugs, but in fact we have not done the job, is pretty significant. So no surprise that there is a relatively high rate of post-PCI residual or recurrent angina. Again, the average number here is 27%, which is understandable because a number of people are sent home while the angiographic result is fooling us and they don't have a good physiology. But I'd like also to draw your attention on the shape of this curve here. Each dot is a study. The size of the dot reflects the size of the study, obviously. And there seems to be an incompressible, shall I say, rate of residual recurrent ischemia after PCI, around 20%. And that's where perhaps events that are taking place in the microcirculation can play a role. So that's where we have all the room for improvement. And as a matter of introduction to what my dear colleagues are going to illustrate for you in the few minutes, what we are really passionate about is the fact that from AI-enhanced image-based analysis, we can now approach and compute and understand the 3 layers that we need to tailor individual treatment. I spoke a lot about epicardial coronary artery disease in those slides so far, and micro-FR is allowing us to compute that from a single angiogram. From the same angiogram, it is possible to compute microvascular and I'll show a few illustrations of that. And finally, very importantly, what so far has been impossible, can you realize that today it is possible to predict plaque vulnerability from image analysis, and that's called radial wall strain. I'll introduce it in a minute, and the colleagues will show you all the data that support the evidence in favor of using these three pillars of understanding coronary artery disease. Now, it starts with a good quality angiogram. The great news is that with micro-FR, one view is enough. You don't need to go through pseudo 3D reconstruction. You have, of course, quantitative coronary angiography for granted, but at the same time, you can obtain two things. The upper right pattern is the mu-FR, micro-FR pullback. It gives you the pressure loss from ostium to apex, and it superimposed and inherently co-registered with the size of the vessel. The shaded area that you see there represents the dimensions of the vessel from normal with stenoses all the way down to the apex. And the lower right graph is this new analysis of radial wall strain, which is in a way a simplification of shear stress. It does not incorporate the three dimensions of shear stress, but it is available from the angiogram. It is basically cross-sectional and is telling you a lot about the risk of rupture and plaque vulnerability. And so the beauty, the thing to remember, angio-based mu-FR, microvascular resistance, and radial wall strain can be obtained from AI-enhanced computations. It's based on angiography only. It does not need any additional invasive procedure or hardware. And the power of the solutions that Pulse Medical is proposing is that it doesn't really interfere with the workflow in the cath lab because it is available within minutes after acquiring the good quality angiogram. So, couple examples now for the next few slides. And if there is a burning question, I can address it now. You just tell me, Prof. Tu. If not, we'll come back to the chat after the talk. So this is what can be called endotypes. It is an illustration, a graphical illustration, or measurement, shall I say, of how much and to which extent accumulation of coronary disease does affect the physiology along the vessel from ostium to apex. And let's take one example, upper left. So follow me. Upper left, you see a curve that goes from 1 on the vertical axis on the right, which is a totally normal physiology. And for a number of millimeters, as you're going from the ostium towards the left main and the LAD, you see there is no pressure drop. And then all of a sudden, coinciding with this reduction in the gray shaded area, which is in fact a coronary stenosis, a significant one, you see there is a very focal pressure drop. And once you've gone beyond that, okay, you have again a flat, an absence of pressure drop along the vessel. So this is a focal endotype. The ideal situation, if you need to be treated with a stent, this is absolutely the best case because you know that stenting will resolve this pressure drop and restore the normal conductance. Yeah, and just below it is the opposite, not so easy to treat, because here you cannot identify any focal spot where most of this curve goes from blue to red. It's actually diffuse. You can't stent it with metal from A to Z, so treating that is more difficult, but you can at least identify it. Now, this information is available from the coronary angiogram without any other measurements or hardware. And you can immediately think how powerful this can be in helping you to plan your procedure and deciding what would be the best approach for a given patient. And the right upper and lower graphs are showing the option where you have two focal lesions in series or a mixed pattern, a focal lesion that is superimposed on diffuse disease. So this is new understanding on how coronary disease affects physiology from graphically displayed with numbers and inherently co-registered with our GPS, which is the coronary angiogram. Very powerful, and it lends itself to planning. This is an example of how you can actually compute or anticipate what the functional outcome would be of treating this lesion. So the lesion shows it's a focal one primarily. You can decide about the stent length and diameter, and you can compute even before opening the stent package what the post-procedural outcome will be. This is much more powerful than doing the procedure and then computing at the end, because you'll find yourself done case. Now you're going to have to chase the reason for this residual gradient. And this trial that is in press by our colleagues from China, Dr. Chen, shows that if you use this planning tool, you can actually reduce the rate of post-procedural unsatisfactory results, even in cases where you actually already have a pretty good result in the first place. So that is really important for the future. I mentioned about MUFR. It's here again. Now, the MUFR in the same analysis within minutes can be expanded to give you radial wall strain. And the radial wall strain is the graph on the right. It tells you about, it's a percentage actually, about the deformation in the cross-sectional dimension. And what will be shown in a minute is that when you have very high radial wall strain that coincides with a location at the vessel where there is not necessarily a tight stenosis, that is a vulnerable plaque. And so these hotspots, we call them hotspots, actually associate with VP by OCT, and you'll see some of that data in a minute. I'm close to the conclusion of this introduction, and I hope I can share with you our enthusiasm about this new wind. Just a case example. I know it's a single case, but we've seen so many of those. This is a patient who has non-STEMI, okay? The culprit lesion was a tight, very tight occlusion of the circ that was treated. And there was this moderate lesion. It looks at the edge of significant, but in fact, if you measure it, it's not that tight because it's a huge coronary artery. And of course, if you compute the MUFR, in this case, it's 0.9. 0.9, that is the threshold for an optimal result after stent implantation. So even if you stent this, you may not improve this much. And of course, you will have used resources, and a complication is always possible. So we have learned to defer this, not to touch it. And yet, sometimes we're disappointed because there is residual risk. And sure enough, this patient came only a few months later with a very tight lesion. So looking back at this initial angiogram and computing the radial wall strain, look of what we see here, 27%. It's one of the highest RWSs we've ever seen. So this plaque has some features that makes it highly vulnerable, highly likely to become very tight in a short period of time, and yet it wasn't hemodynamically significant at the time we saw it. And the question really is whether this will help us, this technology will help us to identify non-hemodynamically significant lesions that could be treated with stents or other means. We'll have to find out preventively in order to prevent this person to come back within months after the initial procedure with another unstable angina in the lab. because this was the result only a few months later. You look at the progression from left angiogram to the right, very fast progression causing non-STEMI a few months later, while the patient was doing fine on the circ that was treated initially, and the deferred lesion, well, in retrospect, could have been perhaps treated if we can have the evidence and we can identify which ones should be treated out of the many of those mild lesions that we see on the occasion of coronary angiograms in non-STEMI and STEMI patients. So, sorry, we have some data in support of this dream or hypothesis that I just mentioned. These are retrospective data, but they are actually telling us and allowing us to compute retrospectively, what if? So we're talking about safer deferral in non-hemodynamically significant stenosis, and you take any large randomized trial and you go back to the initial angiogram, just like we did in this individual patient. So it can be totally blinded, okay? And you look at these angiograms and you see, okay, what would be the event rate, in this case, vessel-oriented event rates, what would be the event rate if we decide to defer based on the angiogram? What would it be if we decide to defer it on the basis of current standards, which is μFR, non-significant, above 0.8? And what if we combine the two? And then you can see here from the right graph that the residual risk can be very significantly decreased. It's much better to base our deferral decision on μFR than on just the angiogram, even with QCA. But it's even better to combine μFR with radial wall strain in this retrospective analysis. So these data are really key to tell us how large should the study be done prospectively to actually demonstrate this prospectively from a randomized trial. In this case, no imaging at this point, other than the simple angiogram. So I'm going to stop here and offer you a couple statements. I think it's a very positive message. There is a new wind in a PCI that is not just related to new devices, but has the potential to A, dramatically improve patient outcomes, and B, increase our work, because we may have in the future to stent or treat non-hemodynamically significant stenosis. So image-based computational physiology, that's how I like to call it, relies on a number of components of AI. And what is really key is that for the first time, in very simple ways, we can grasp and understand what's wrong at the epicardial circulatory level, what's wrong at the microvascular dysfunction, and which are the plaques that are vulnerable. Now, all of that information is accessible from a good quality coronary angiogram. You don't have to ask for it. The technician or the nurse does the analysis while you're taking off your gloves. It can be done in every patient undergoing an angiogram. It can be examined by every cardiologist in and outside the cath lab. Amazing increase in access to quality of care for the majority of people, I would say globally, without the use of expensive extra devices. So thank you for your kind attention. And this is the new wind. It's blowing very strongly. Thank you.
Okay, thank you, Professor Wise, to share a very interesting topic. And we know that the computational physiology, the plaque vulnerability assessment technology is developed very fast in recent several years. And also the single view, the μFR, the RWS, the AMR, and also provide a much more convenient way for the physicians to make the more precious decision making and also for the planning. And for the question from the audience, maybe if you have any question, you can tap your question in the chat box. And also, if you want to directly talking with the speakers, you can raise your hand and unmute yourself. And Professor Tu or Dr. Jost, and we see that also Dr. Lee also joined in. And if you have any comments, we can also discuss here.
Of course, this was more like an introductory talk. So those of you who want to know more about specific aspects, these will be addressed. But I see there's a question by Paul Evans here.
Yeah.
Can we read it? Sorry. So thank you very much for asking. Okay, the question is, and thank you, Paul, for asking, how can we combine the physiology and vulnerability result together to make clinical decision? Yeah. So the point is that all the information will be available. And I can see that you finish your case, you did your good angiogram, and you tell the patient, let me have a look at the data. You go back to the control room, and there you have the angiogram, QCA, μFR, the profile, the endotype. In the near future, you will have a number for microvascular resistance in the different areas. And of course, you will have vulnerable plaque index, the RWS. And now you have to integrate this very quickly. And we'll have to design some strategic trials, okay, where in a stepwise way, you will use this information to decide what to do. I can't give you the answer. I mean, these trials, prospective trials, have to be done. But if you were to design this, you would probably start with hemodynamic significance, right? If it's hemodynamically significant, you know a lot. If it's non-hemodynamically significant, then you start to pulling in other techniques, particularly RWS, to try and prevent acute events and sudden death by preventative intervention. So strategic trials will have to be designed, which is great in our field because so far we've been focusing so much on devices. Now this is going to have massive impact on patient outcome, including reduction of acute coronary syndromes and sudden death. So work to be done, but thank you for your question.
Okay, we see there is another question, and it's from Nadine Malik. What percentage for the microvascular issues in total MI events? It's maybe about the total percentage of microvascular.
Yeah, love this question. Thank you very much. Now, microvascular at the moment is primarily looked at in patients in whom you have complaints and you have no epicardial explanation, which is okay. And we have all these interesting concepts about INOCA, MINOCA, etc. But it would be, and it will be, much better to actually incorporate microvascular functional assessment in the overall package by default. And so if you're asking me what percentage of microvascular dysfunction in patients with diabetes, we have numbers in selected groups, but these are groups that were selected because they had everything else, kept complaining, and now you measure something. If it becomes available in everybody, we will finally know what is the true incidence of microvascular dysfunction in patients with CAD. Is it present in everybody or not? We had a quick look at some of it, looking at our database retrospectively with Dr. Tu. And you would think that in patients with diabetes, there is more microvascular dysfunction if you measure it in every patient than in patients with non-diabetes. It's not the case. It's about 50% in both. I mean, retrospective analysis from a group of a couple hundred cases, but we will start finally now to understand all these components, all these determinants of the outcome of patients with CAD by measuring it systematically in everybody. So I don't know the answer to your question that is a fundamental one, but what I know is that we're going to move away from looking at super selected patients groups that are very interesting. They were addressed with, sophisticated techniques, flow wires, acetylcholine tests, etc. We can have a simple index in the near future of microvascular resistance from the coronary angiogram. It's not as advanced and as validated yet as, for instance, MUFR, which is very strong, RWS that I think is strong, if not very strong. This one still needs more validation, but very soon we'll have it. And now we'll understand the different components of the puzzle in every individual patient. So that's going to be personalized care.
Okay, thank you, Professor Wise. And here we see a new question. And can you talk a little on the effect of sand branches on the flow with the technology? Because he believes this is considered with this technology, which is different from the pressure wear or other similar technologies.
Thank you for this question. I don't know who did ask it. Robbie Dolan, thank you. I mean, you are obviously very much into bifurcation and physiology because your question is extremely relevant and to the point as well, like the two other ones. Now, because MUFR and Prof. 2, I suppose, will explain it, because MUFR is incorporating Murray law, the fractal Murray law, in the computation, for the first time, it gives you the MUFR in the side branches. Okay? And you can actually obtain that information pre-procedure and post-procedure. Obviously, once you're manipulating the bifurcation, a non-hemodynamically significant side branch by MUFR can be significant at the end. You see some funny image after provisional stenting, you need to treat it or not. If you use, shall I say, insensitive clinical endpoints in relatively small groups, typically you won't see much whether you treat it or not. Now, for the first time, we will have objective means to assess strategies like two-stent techniques or provisional stenting by really incorporating physiology in the decision tree. I'm not saying physiology is going to be everything, but at least we'll have the information. And not sending home a patient with a stenotic large side branch without treating it, this can be avoided because you will have the MUFR in that vessel at the end of your procedure.
Okay, thank you.
So lots of opportunity for great research. And I hope that groups like the Bifurcation Club will start looking at this.
Okay, thank you, Professor Wise. And I think there's still some question in the chat box, but we can move on and answer all the questions after the meeting. So
yeah, I think that sorry to interrupt, but I think the one question on RWS and CT will be addressed by a colleague during one of the upcoming talks. So stay tuned. Okay. You will have your answer. Thank you very much. Okay. Thank you all.
Thank you. Thank you again. And okay, for the second question topics, we can move on. And let's welcome Professor Tu from Shanghai Jiao Tong University to give a presentation with the title of Computational Physiology and Plaque Vulnerability, Methodology and Validations. Professor Tu, please.
Thank you, Professor Dice, for this great introduction. So we'll follow it with more kind of demanding on the brain. So we'll explain a bit about the methodology and also the validation for these technologies. So this is my disclosure. So for alpha, how can it be computed? So in theory, the alpha can be approximated with the pressure ratio under maximum hyperemic conditions. This has been demonstrated in previous study. So if you want to calculate them, we know that there's a pressure drop because of the stenosis. So if you can calculate precisely the pressure drop under maximum hyperemic condition, then you can calculate FFR, and this is the most important element in the computation. So if you want to calculate pressure drop, And this has been illustrated in two of the review paper as well as the PCR textbooks here. So basically, we need to have two elements ready. One is the geometry, which you can reconstruct the coronary vessel by either three or single vessel, curved or bended or straighted. Second, you need to have the hemodynamic boundary condition. So in this case, you will estimate the maximum hyperemic flow. So with these two elements ready, then you are ready to calculate. So you can use either computational fluid dynamic, which is more computational demanding because you need to do meshing and flow simulation. So usually it needs a supercomputer. And second is you have the simplified fluid dynamic equation, which you can calculate with a normal like laptop. So this would be the basic principle. And so from CT, we can calculate CT, QFR, NGO from QFR, MUFR, and OCT from OFR, and also IVUS from UFR. Again, I explained the methodology with this slider. As you can see from imaging, we need to create a geometry. So it can either by 3D or later on by 2D. And then you have to estimate the maximum hyperemic flow and calculate the pressure drop using either the CFD or fluid dynamic equation. Then you can calculate FR. So this would be the simple principle. I'm going to give an example using QFR. So QFR is, you can use the 3D reconstruction from two angiographic projection to get the vessel geometry. So how to get the maximum hyperemic flow? So normally if you get contrast, again, have the contrast flow, then you can calculate the contrast flow velocity using the Timmy frame counting. And then behind the computer will convert into a theoretical hyperemic flow velocity using the formula here. Then we calculate the pressure drop. And then you can get the QFR at every location. And so you have a pullback. So the FAVOR pilot study was the first study to try to test which flow model would be the best for QFR computation. So we can have three ways of obtaining the maximum hyperemic flow. The first one, we call it fixed flow QFR, meaning that you are assuming that every patient has the same fixed flow velocity. It's not the fixed flow volume, it's the fixed flow velocity because the size of the coronary will be different. So we're assuming the fixed flow velocity for every patient, maximum hyperemic flow velocity. And the second model is the contrast flow or the CQFR, where you're using the contrast flow velocity and then convert into a hyperemic flow velocity. The third one is we call it adenosine flow QFR, where you really give adenosine, induce maximum hyperemic aquatic angiogram under the maximum hyperemic condition, and you calculate QFR, we call adenosine flow QFR, AQFR. So in this case, these three are almost the same, they're very close by. So what are the results of the FAVOR pilot study? The FAVOR pilot study shows that if you use individual flow velocity by using Timmy frame count, as you can see, it slightly improved the diagnostic accuracy compared to the fixed flow QFR. However, if you give adenosine to induce hyperemic calculate QFR, it does not improve much, or it's almost comparable. All these three QFR models outperform the diameter stenosis significantly. So from this study on, we use CQFR as the QFR by default. Then subsequently, we test the diagnostic performance of QFR inside the cath lab online in procedure. So we calculate QFR and then we perform a well-based FFR and use them as a reference to validate the accuracy of the QFR and in the FAVOR 2 China study population. The result shows that if you do it prospectively in procedure, then the diagnostic accuracy can be high up to 92.7%. Then we continue to improve the technology. As you can even might notice that QFR can only do a single vessel reconstruction. So in the calculation of QFR or pressure result, not only the lumen diameter need to be taken into account, but also the reference side. The reference lumen is the healthy lumen as if there was no stenosis. But if you have a bifurcation lesion here, as in this case, the reference lumen can only be assumed linear tapering because you don't have the side branch into account. If you don't reconstruct the side branch, the maximum you can do is assume this linear tapering. So you will have underestimation of the reference lumen proximal to the bifurcation, or overestimation of the diameter stenosis distal to the bifurcation. So in the second generation, we introduced this Murray law, bifurcation fractal law. So it's a step down reference diameter. If you have a big side branch, you will take away more flow, so the healthy lumen will step down more. So this will be more accurate to approximate the healthy lumen in physiological conditions. So in this second generation, sometimes you see confusing name. So we are using MuQFR, and later on we change to MuFR in all the application outside China. So this solution, or this MuFR, also work with a single angiographic view. So this would increase the feasibility, because sometimes it's difficult to get a second good view. So if you use single view only, that you increase the feasibility. And as I just explained, if you include side branch, you will increase the accuracy because you can calculate more accurately the reference lumen. And we also automatically frame counting. That means that even the AI, then you can improve the efficiency in the analysis. So using the favored to China study population, you run this single view MuFR again in the optimum projection. Then as you can see, the diagnostic accuracy can be 93% in this optimal projection in high quality data set with high quality pressure tracing data as well. Later on, we extend the analysis to a larger study population. So we perform a post-hoc analysis of all the vessels with FFR in the flavor 12. As you can see, even post-hoc analysis, the feasibility can be as high as to 95%, because you use only single angiographic projection. It was a blind analysis in the core lab. As you can see, the diagnostic concordance which FFR was 90, which is also a good number. So this single view MuFR is only available currently in the Angioplas core software by Postmedical. So this has stayed in the consensus paper. And as I mentioned, that sometimes you see different slider using the different name. So the CT QFR is MuQFR. The name has been changed to CT MuFR and MuFR in the post product outside China. So what are the difference in the diagnostic accuracy between 2D and 3D? So in order to answer this question, we perform this study. So in this data set, all of the case has two good angiographic projection, which were the recommended projection. So we calculate MuQFR in one projection and second projection, and also we perform the most sophisticated 3D reconstruction because we include all the side branch in the reconstruction and calculate 3D MuFR. And this was the result. As you can see, the single view MuFR is as accurate as the two view or 3D MuFR. which was a bit surprise to us at the beginning, but maybe I can explain a bit why we have this result. So many of cases we know that there's eccentric lesion, but actually the lumen can be symmetric. So eccentric lesion and symmetric lumen, as you can see from this case here. So the lumen are round, so no matter which angle you are projecting, it will be a round lumen. So if you project it, the first view in vertical direction, you get this shape. And then if you project along this direction, then the lumen becomes center here. But this lumen still symmetric lumen. So if you perform a perfect correlation between these two views, then you will get the accurate 3D. So you get round lumen in these two cross sections here. So no problem. However, if you perform the 3D with imperfect correlation, that means that you might have some misalignment between these two position cross section here. Then you will get a elliptical lumen, proximal and elliptical lumen distally. So this actually is not more accurate than single view. So this could compromise the accuracy of the 3D reconstruction. And also, you don't know that the second view can be as good as the first view. Normally, it's difficult to get a good second view. That's explain why we did not find improvement using two view compared to the single view. So the current workflow for MUFR we suggest is that if you transfer the data to the system, we are using the select the best projection with a minimal overlap and for shortening. We perform the automatic flow velocity calculation and also perform the MUFR in both the main vector and side branch in this single view. And then only if you see that there was a second good view, and if you can identify that the lumen is asymmetric, means that you can see there's different narrowing in the second view. You will include them in the 3D. Otherwise, you will use the single view MUFR as your result. This is the current recommended workflow we suggest. So I'm going to show how fast can it be done now with the Angioplast core software. This is the recording in real time to show you that we can actually make it fully automatic. So if you only need to select the projection for analysis. As you can see, the computer is detecting, select the best frame for analysis for you, and then you also detect the segment which is suitable for analysis, and then calculate all this MUFR under the background. This is not a black box because you can still verify that whether the lumen contour detection is accurate or not. If not, then you still need to manually correct them. So in this case, if you have a good image quality, most of the case you don't need further correction, and you can leave it like this. In this case, the MUFR is 0.72 in the most distal position, and you have the pullback correlation with angiogram showing every location. And see the number here, when it's approximate to 1, that means that your reference lumen is more or less following the bifurcation fractal law. When it's close to 1, it's the best. So how accurate of this fully automatic MUFR? So we present this one at EuroPCR this year. So without any user correction, as you can see, the diagnostic accuracy was 84.9%. So slightly decreased compared to the core lab analysis, because in core lab analysis, if you identify something suboptimal, you will correct them. But at least the ultimate complete photo automatic one can still have a good diagnostic accuracy. And the analysis time is only 23 seconds on a normal laptop. So this does still not solve all the problem. There's still unmet clinical need. Because sometimes even single view is difficult to see if you get a good projection without overlap with exposure of all the lesion. And also when you have stent strap implanted, The angio does not tell you that whether the stent is opposed to the wall or there's an underexpansion there. But intracoronary imaging can provide more accurate information in this. So we further develop or extend the MUFR to OCT IVUS image. So we compute the OCT-based FR called OFR or the IVUS-based UFR called IVUS-based FR called UFR. So like you reduce these two invasive procedures into a single procedure, and the software looks very similar. So the OFR and UFR software, as you can see here. So how does it work? Remember that we need to get the geometry and also need to do the obtain the maximum hyperlimic flow, and then we calculate the pressure zone. So this is also the same for OFR and UFR. So first you do the automatic OCT or IVUS lumen contour delineating and 3D reconstruction. And second, we will reconstruct this side branch cut plan. So we need to have the size of the side branch in order to have this step down reference diameter. And the best thing you can do is that you can get the plan perpendicular side branch center line. We get this cut plan and then analyze the area of the lumen here, and then try to have this more accurate reference lumen. And then we estimate downstream diffuse flow and compute OFR, UFR. And this has been tested in several publications, study. So last year we performed a meta-analysis and put all this OFR validation study together. As you can see that in general, the diagnosis accuracy was high compared to the FFR. But before PCI has a better error under curve than the post-PCI setting. So furthermore, we noticed that IVUS OCT sometimes does not cover the entire entire lesion because the pullback is short, especially for OCT. So we want to integrate angio with intracoronary imaging to have a more accurate calculation of FR, and this has been implemented in the version 3 software of Angio plus Core. So we can coalesce the angio with OCT with the side branch, and then we can merge the angio and OCT together, because for OCT, it is the OCT standard OCT imaging segment, this is angio segment. We combine them and have this OCT modulated MUFR. And we saw that indeed there's a small improvement if you perform OCT MUFR compared to the MUFR alone. And the improvement was mainly in those cases where you don't have the good angiographic image projection quality. The same has been integrated in the IVUS, so the UFR software, and recently has been integrated into the IVUS console by Postmedical and including the tester. So now using the same console, you can perform UFR and IVUS imaging in the same console with the same tester. And for CT, how do we do it? How do we also solve the flow estimation? We did not perform the myocardial mass segmentation. Instead, we reconstructed the healthy lumen, as you can see here. And based on the healthy lumen, we assume that there was a correlation between the healthy lumen and also the sustained myocardial mass. So we can calculate the hyperlimic flow velocity based on this assumption, and then using the MUFR algorithm to calculate the CT MUFR. This has been demonstrated in the figure here. And recently, we collaborated with a hospital in Zhejiang, and select the CT with good image quality. As you can see, if the CT has really good image quality, the CT MUFR can be quite reliable. So you can see the balance concordance is about 92%, but only when you have CT with good image quality. And we further tested in the prospective study, the CLEAR study. So this is the prospective study, used the CT MUFR online. And as you can see that using the FR and the MUFR hybrid, FR and the MUFR as reference standard, The CT-MUFR has a dynamic concordance of almost 90%, and the average analysis time for CT-MUFR is about 8.7 minutes. And also it can be run on a simple computer. So furthermore, we present the study for the validation result for fully automatic CT-MUFR, so without any user interaction. And this has been made feasible also with the software and tested in this prior study population. As you can see that the average analysis time has been reduced to 1.6 minutes. So 3% cannot be analyzed because the vessel, most of them are subtotal occlusion or CTO vessel. So using fully automatic CT-MUFR, the diagnostic accuracy slightly decreased from 89 to 83, but still remain high diagnostic accuracy. And the last topic is about the vulnerable plaque. This has been very interesting in the field to be able to assess the vulnerable feature from imaging. And OCT provide the best resolution. So use in the OFR software or OCT Plus software, during the OFR computation, actually we automatically characterize the plaque composition in all the cross section of the entire pullback using the deep learning or artificial intelligence. So this has been validated against the core lab consensus by 3 leading core lab in the field. So we pull out their consensus and then use it as a reference standard. As you can see, the annotation result, the AI result are very similar. And also, not only can calculate the plaque composition, you can see that it can also estimate the size of the media, so the IEL. So although you don't see them from the image, but the AI using consecutive slides estimates the media size. And this could be quite interesting because you can know the size of the vessel wall. And also you can calculate the individual plaque composition, plaque burden. And this has been very useful if you want to further assess the plaque vulnerability. So we propose this new index called lipid to cap ratio as a new vulnerability index. So the lipid to cap ratio is calculated by the lipid burden divided by the cap thickness. So it's a continuous variable. The higher value, the higher risk. As you can explain, it can be explained in this example. It can be quite different from TACFA. So TACFA is a binary variable. So by definition, the TACFA is defined by cap thickness less than 65 micrometer and lipid up more than 180. So by this definition, plaque A is TACFA, plaque B not. However, by the definition of LCR, plaque B has a higher risk because it's bigger lipid burden here. So we further tested in a study with Harbin University Hospital in 915 vessels from 604 ACS patients. Using 2 years clinical outcome as a reference standard, you can see that LCR predict better the outcome than the TACFA. But first, still you need using OCT tester, and it's a bit still costly and it's not performed in every case. It's an invasive procedure. Can it be further simplified? So I propose the concept of angiographic derived radial wall strength. So the concept is that if you have a vulnerable plaque, for example, in this case, you can have a large lipid burden and thin cap here. The blood pressure is changing during the cardiac cycle. There's a pressure difference between systolic pressure and diastolic pressure. The pressure change will interact the plaque composition. So if you have a more lipid composition and you have a thin cap, then there will be more deformation there. So it's reflecting in the maximum lumen deformation, the vulnerability. And actually this information is hidden in a dynamic angiogram. Although visually it's very difficult to see the change of the lumen size over the cardiac cycle. But if the computer the AI algorithm can be reliable enough to detect the subtle change and then co-register the diameter. And you can quantify the radial wall strength. And this gives you the possibility to assess the vulnerability by angiogram. So this has been implanted in the AngioPlus core software. So using the single view mirror file, and then if the image quality is good, you click and then you get the co-registered radial wall strength map. The red color is the hotspot, indicate that there was more vulnerable plaque behind this. So we have tested in a number of studies. This is the first study to compare with the OCT-derived radial wall strength. The OCT-derived lipid to cap ratio, as I explained before. So the angio-derived radial wall strength predict the OCT-defined vulnerable plaque by this lipid to cap ratio bigger than 0.63, with the error under curve of 0.86. We also further shows that the radial wall strength can predict the CTA-defined high-risk plaque characteristic. As you can see, the more number of the high plaque characteristic, the higher radial wall strength. And we saw that even if you have a CT-defined high-risk plaque and also FR, if you add the radial wall strength in the analysis, you can still increase the capability to predict target vessel failure in this study. And the other base shows a direct prognostic effect on target vessel failure, not mediated by FR or high-risk plaque by CTA. And in a recent study that still just finished, we analyzed the target AC12 with data from European population, more than 1,000 patients. And we saw that the radial wall strength can clearly differentiate the high risk of the patient with worse clinical outcome in 5 years compared to the vessel with good outcome. As you can see here, the hazard ratio in the entire cohort is 3.8. If we only include angiogram with good image quality, high image quality, then the hazard ratio can be up to 5.5. So, ladies and gentlemen, in conclusion, angiogram QFR mirror is a feasible substitute for pressure-aware-based FFR management, and use of it to guide PCI has been associated with improved clinical outcome compared with angiographic guidance. The diagnostic accuracy of single angiographic view-based neurofar is non-inferior to 3D neurofar. And computational coronary physiology can also be performed from other invasive and non-invasive imaging modality, thus enable the identification of hemodynamic impact beyond coronary anatomy and plaque characteristic. Angiographic derived radial wall strength from a single angiographic projection is a novel indicator of plaque vulnerability, and higher RWS is associated with coronary lesion at increased risk of future events. And thank you for your attention.
Okay, thank you, Professor Tu. And we know that thanks for sharing the methodology and the validation about these different novel technologies. And I think all the technologies mentioned before is very fully validated. And also, I think this is the most first question from the doctor. How can you compute these parameters from the image? And also, we know that the new parameter like the RWS is quite interesting. And I think maybe Professor Tu, you can help to answer the questions before. I think this question is from a doctor from Middle East. So is using RWS technology useful for the screening of cardiovascular events in the future? And is this possible in the CT image based?
Very good question. So the concept of radial wall strength is actually you have to analyze multiple phases of cardiac cycle. So if you perform CT, so if you do retrospective gating, then in principle it's possible. but you will have more dose. If you do prospective gating, it's not possible.
Okay, thank you, Professor Tu. And also here is another question about RWS. How does RWS correlate with traditional parameters of CFD analysis? It's from Dario Pellegrini.
So the radial wall strength is a strength analysis of strength. So the CFD is more like analyze the pressure drop or the wall shear stress. So these are different. So the wall shear stress is like induced by the fluid. The magnitude is smaller than compared to the plaque stress or plaque strength. So plaque stress is really the mechanical stress. It's induced by the like compression of cardiac myocardium and also the pressure interacts with the plaque composition. So these are different, so they cannot be directly compared.
Okay, thank you, Professor Tu. And also thanks for the answering from Professor William Weiss. We see that you also answered some questions for the audience.
Thank you, Professor.
And yeah, and also for the another question from Salam. So maybe you can call the Salam. So you have both 2D and 3D MUFR, and can you suggest exactly when to use 2D and when to use 3D?
So what we recommend is that we always start with the projection with the best quality and perform 2D. And only if you have a second good projection. And also only when you see that in the second projection, the narrowing of the lumen is different from the first view, then we will do 3D. Otherwise, we will leave it and then use the 2D result.
Okay, thank you. And also another question from Siraj. What's the correlation between RWS and the FFR?
Thanks for your question. So radial wall strength is actually different compared to the FFR. So I don't think that is useful to analyze the correlation there. But there's some maybe there's some link there, because if you have a more narrowing, almost stenosis, you have a higher chance of developing a vulnerable plaque, and the FR will be lower. So these are the sort of interaction there. But in principle, these are two different animals.
Okay, thank you, Professor Tu. And another question from Wendy. The concept of RWS very interesting, and what are the factors that may influence the accuracy of RWS analysis?
So very good question. So the RWS is very demanding on image quality. So first of all, you need to have after contrast complete feel the distal position, and you have one more cardiac cycle. Otherwise, we cannot calculate the radial wall strength. So it's more demanding. So you give a little bit the more contrast dye. Second is that because the change is subtle change, so the contour, the lumen contouring is very important. So you need to have a precise lumen contouring. So image quality, exposure, the lumen, the lesion need to be optimal. These are the second important second important factor. The third one is that it will be better to acquire the angle in optimal projection. That is, we are currently working with Zhongshan Hospital a prospective study to understand that what would be the best view to analyze the RWS. So this will be answered in the near future.
Yeah, thank you, Professor Tu. And also we see that Professor Weiss also share his comments to the relationship between RWS and FFR. Many ischemia stenosis by MUFR also has higher RWS. So probably this explains why PCI reduce MR rates. Thank you, Professor William. And so I think maybe we can go to the third part. So welcome Dr. Joost Damo from Netherlands. So today he's going to share the topic with the computational FFR from different image modalities, current evidence. Dr. Joost, please.
Thank you for the kind invitation to present here on this very interesting webinar. Let me share my slides. So the title I was assigned today is to talk a little bit about computational FFR from different imaging modalities, with a particular focus on the current clinical evidence for the use of the different modalities that just have been presented by our two colleagues. So the clinical evidence for QFR is now building up basically since the last decade with a series of studies from the FAVOR series, with the initial FAVOR pilot trial, as Professor Tu nicely elaborated on, presented and published in 2016 to identify the appropriate model to computate QFR, whether that would be with a fixed flow or contrast flow or hyperemic flow model. A prospective validation was subsequently performed in the FAVOR 2 China study, in which QFR was used online, in which our Chinese colleagues actually confirmed that if you use these technologies outside the scope of a core lab in a routine clinical practice setting and computate QFR online, you can get similar diagnostic accuracy figures as compared to when you do these in a core lab setting, which is a very important finding, which was a step up actually to a next clinical trial in which the QFR index was used in a large randomized clinical trial called FAVOR 3 China. More is underway in the sense of FAVOR 4 QVAS and FAVOR 5 MI, which we will elaborate on later on in this presentation. I will take you in the next 15 to 20 minutes to the data that has been gathered thus far and give you a little bit of a flavor on what these technologies could mean to you when you use them in routine practice. And to do so, I would like to start with the FAVOR 3 China study, which was an incredible trial because it was the first large randomized controlled trial actually assessing the use of angio-based physiology, in this case with the QFR index versus angio-guided PCI in a large sample of patients that presented either with stable or unstable coronary artery disease and had intermediate coronary artery lesions as defined to lesions which had a percentage diameter stenosis by visual estimation of somewhere between 50 and 90% in a coronary artery with a diameter of at least 2.5 millimeters. So that's important to highlight because those are in principle the lesions that are amenable to physiological lesion assessment using any type of physiological index, but in this case, QFR in particular. Exclusion criteria, very importantly, as with FFR, vessels with a clear lesion and intima flow below 3 were not amenable for enrollment. So those were exclusion criteria. Finally, our Chinese colleagues managed to randomize 3,830 patients and subsequently randomized them one-to-one to either a QFR-guided treatment strategy versus a angio-guided treatment strategy. Cutoff for QFR 0.80 as with FFR, and as mentioned, vessels amenable to QFR assessment and randomization had to be those with a diameter stenosis as mentioned between 50 and 90% and the reference vessel diameter above 2.5 millimeter. So what did that entail finally? So the trial was powered for primary endpoint being 1 year MACE, defined as a composite of all-cause death, MI, or ischemia-driven revascularization. First, on the left, I'll take you briefly to the key procedural results, because what was striking in this physiology trial, that PCI was performed virtually in all patients that were included in the angio-guided PCI arm. So please note the enrollment criteria of these trials. Lesions really had to be above 50%, in contrast to some of the other physiology trials we've seen in the past, in which the cutoff for enrollment was somewhere between 30 and 90%, with varying cutoffs in the previous trials. But that said, 99.1% underwent actually a PCI in the angio-guided group versus 90.5% in the QFR-guided group. So this to me is one of the first important findings of this trial, so that if you use QFR in routine practice in the setting of a large randomized controlled trial, you decrease the likelihood of performing PCI with about 10%. That subsequently resulted in a significant reduction of procedure time by about 6 minutes, which was statistically significantly lower as compared to the angio-guided arm. That with respect to the procedural result, but perhaps more importantly is the outcome. So our Chinese college managed to show us that if you perform a QFR guided revascularization strategy, you are able to reduce your primary endpoint of MACE with 35% at 1 year. 8.8% MACE in the angio-guided arm versus 5.8 in the QFR guided arm, which again resulted in a 35% reduction in the primary endpoint. What most of you will notice is that the event curves actually already separate from day one. So that already illustrates that the event difference is partly driven per procedural MI, which is somewhat obvious because you simply perform more PCI if you do a angio-guided PCI approach with a subsequent inherent increased risk of per-procedural MI. Taking, however, out these paraprocedural MIs of the equation and look at the difference in somewhat, let's say, post-hospital potential benefit of this revascularization strategy guided by QFR, still reduces the event rate by 36%. So 4.8% events versus 3.1 in the QFR guided treatment strategy, even without the paraprocedural MI. So a very strong and consistent finding, irrespective of whether or not you include your paraprocedural MI in the endpoint. These patients were obviously all followed up to 2 years. These results were presented by Li Song and published in JACC 2 years ago, showing a very consistent benefit in terms of reducing events in the QFR guided versus the angio guided arm, with a landmark analysis that actually confirms obviously the benefit at 1 year, but also illustrates that even beyond 1 year, so let's say between 1 and 2 years, you have a potential and likely persistent benefit of a physiology guided treatment strategy using QFR in this Asian patient set. A little bit more detail into the revascularization strategy. So this was a subgroup, or not so much a subgroup, but more an in-depth analysis on how a QFR guided analysis actually impacted treatment strategy. And what you can see here is that deferral, so non-treatment of at least one vessel that was originally intended for PCI, occurred in about 20% of the QFR guided arm. So that's basically 1 in 5. Whereas conversely, vessels that were initially to be deferred for PCI actually underwent PCI due to a positive QFR, happened in 4.4% of the patient. Obviously, significantly more often than the angio-guided arm, in which the revascularization strategy was basically completely in line with what people intended to do based on the exactly the same angio. Let's proceed. The Favor 3 China by 2024 also published some subgroup analysis as what you would expect from most large-scale randomized controlled trials. In this case, a diabetes subset showing you no heterogeneity of the treatment effect in patients with diabetes. So consistent results in patients with versus without diabetes. A similar, but in my opinion, perhaps a similar interesting analysis, those based on gender. We know that invasive physiology may be impacted by gender, as female patients tend to have some more microvascular dysfunction and tend to have some higher FFR values as compared to male patients. That was not particularly found in Favor 3 China, but what the investigators did find is that, again, the treatment effect of this QFR guided approach was comparable between males and females, as you would expect, because obviously the algorithm doesn't account for gender. So again, a potential advantage of this particular technology. Another subset analysis I briefly wanted to highlight is those on functional complete revascularization. This is an important one because, as you know, patients with multivessel disease are typically discussed in the heart team And what we've learned over the past 2 decades is that whatever we do, we should try to pursue complete revascularization in order to get the best out of a revascularization strategy. And that's likely where a CABG patients in some studies tend to do better as compared to PCI, simply because of the rate of complete revascularization tends to be somewhat higher. But obviously, there's another way to look at this, and that is to use a parameter called functional syntax score and residual functional syntax score based on what you can get from your invasive physiological assessment using angio-based physiology. And if you do that, and if you see what you can achieve in terms of residual functional syntax score, that is somewhat higher in patients who underwent a QFR guided treatment strategy, because you simply do better lesion stratification upfront. But more importantly is that you also get better outcome in patients in which your residual functional syntax score is 0, which is obviously what you would aim for. In this case, on the left, 5% events versus almost 20% in those in whom you did not achieve this residual functional syntax score of close to 0. Numerically, 6% more patients in the QFR guided arm that actually achieved this functional complete revascularization. So again, an argument to use this technology in patients in which the culprit lesion is not completely clear, and in those cases in which you have a intermediate lesion with a diameter stenosis of somewhere between 50 and 90%. Cost effectiveness, this is obviously an important topic in contemporary clinical practice. This is an analysis performed at PCR, but basically indicated in Chinese 1, showing you that if you perform a QFR guided treatment strategy in a Chinese cost effectiveness model, that would result in a cost effectiveness difference of about 2001, which is in euros, if I'm not mistaken, about 250 euros. So a benefit that is statistically significant different, and also what you would expect specifically because you simply perform less PCI in those patients in whom you perform a QFR guided approach. So obviously more to come on cost effectiveness. This needs to be validated also in Western models, but it's highly likely that these Chinese results can be replicated elsewhere in Europe. The benefit of a physiology guided approach using angio-based physiology should result in consistent cost effectiveness benefit in these studies. So as mentioned already, so the first and largest clinical outcome trial to date was performed in China, but this is just a slide to show you that there's more on angiography-based physiology. As you know, there are multiple competing technologies that all have large-scale outcome trials on the way. Particularly important in light of this webinar is the Phase 3 EU-Japan trial, which, if I'm not mistaken, will be presented at the upcoming TCT meeting. It's a trial that was largely performed in Europe under the leadership of Press 2 and also Niels Holm from Sweden. But also Phase 3, a large-scale randomized controlled trial that was finished here in Europe also recently. Lipsia strategy with the biomedical technology and several studies with competing technologies also from other places in the world are currently ongoing and will be presented hopefully in the course of next year. That said, there's more on the use of QFR or MUFR as used in a contemporary setting with the Pulse software. And one study I wanted to highlight is the ACFA-2 trial, which is a trial under the leadership of Simone Biscaglia, actually very recently published in JACC Intervention, in which the investigators tested the hypothesis that a physiology-guided revascularization strategy would result in higher post-PCI physiological values as compared to an angio-guided PCI approach. And with that, the investigators actually tested the virtual stenting concept with MUFR as well as a microcatheter-derived FFR technology to perform revascularization. Primary endpoint of the trial actually demonstrated a significantly higher post-PCI FFR in those cases that underwent physiology-guided PCI, so being it either a technology with the novice of assist, so microcatheter-derived FFR versus a QFR-derived technology. So 0.90 on average post-PCI FFR in a physiology-guided arm versus 0.87 in the angio-guided arm. A subsequent analysis to test whether there would be a difference between conventional physiology, in this case with a microcatheter, versus MuFR resulted in no difference, actually completely identical findings with a mean of 0.89 in both arms. So with that, the authors were obviously able to conclude that they should pursue a physiology-guided approach, which could be QFR or MuFR, the likelihood that you will achieve optimal post-PCI, in this case defined as those with a post-PCI FFR above 0.86, it was 77 versus 54%, which is a relative difference of 30% in favor of a physiology-guided approach. So with that, another strong argument to use physiology in a pre-PCI setting, with the advantage of these technologies that you can very easily also test it post-PCI. That is a topic per se that was a topic of debate in the last decade in a variety of trials, and for a reason. Because if you test the use of FFR in a post-PCI setting, as Professor Wines already indicated, you will be able to identify those patients at the highest risk of future adverse events. Multiple studies were performed using MuFR and QFR in a post-PCI setting to first assess whether there was a predictive effect on outcome, but second, also to look into potential differences once different treatment strategies were applied. And one was the test of MuFR in the Forza trial. So just to remember you, Forza was a randomized controlled trial from Italy comparing a OCT-guided versus FFR-guided treatment strategy. And what was used for this analysis was the 3-year outcome, which basically was not statistically significant different at 3 years, whereas, by the way, the results were significantly in favor of OCT at 1 year. But if you do a post-PCI MuFR in these vessels, you would have found that patients with a post-PCI MuFR above 0.89 had significantly lower events as compared to those with a QFR below 0.89. And that's exactly in line with what we've observed in the last decade in a lot of trials in which post-PCI physiology using conventional FFR was linked to outcome. So just to say, QFR or MuQFR can be of a great use in identifying those patients with the highest risk of future adverse events. A more in-depth analysis was also performed here in patients that underwent left main bifurcation stenting, a topic of great interest because we know that residual lesions, particularly in a circumflex branch, which was stented in patients with left main disease, result in a high likelihood of future adverse events. This was a subgroup analysis of, or an analysis, I should say, of almost 1,200 Chinese patients that underwent left main branch PCI, in which a post-hoc analysis was performed using MuFR in the LAD and circumflex. So what you would expect is that in patients with a high non-ischemic MuFR in LAD and circumflex, in this case the blue category, patients have the lowest risk of adverse events. That's exactly what the investigators found, 1.3% of death, and the bifurcation-oriented endpoint occurred in 5.8. Conversely, if you fall in the red category, which is the danger, or let's say the most, perhaps most dangerous category is those patients in which the FFR and the LAD is okay, but in the circumflex is reduced, that occurred in 10% of the patient, then your event rate starts to accrue significantly and goes up to 17.2%, CV death rates even 6.2%. So just to say, this technology allows you to assess in a post-PCI setting your angiographic result, but also your physiologic result when using QFR. So a technology that has a widespread use of indication, including left main stents as shown here. More on QFR, so if you divide these patients in a high versus low QFR, you obviously also in this large bifurcation trial were able to conclude that patients with a QFR below 0.8 obviously had significantly higher event rates, in this case 17.8%, as compared to those with low QFR, with high QFR, in which the event rate was merely 5.8% at 3 years. Flavor post-PCI is similar analysis, basically, in which MUFR was assessed in the randomized controlled flavor trial. So 800 patients randomized to either FFR or IVUS guidance. MUFR was computed in a set of 283 patients in the FFR guided arm versus 494 in the IVUS arm. And again, a clear confirmation that if MUFR is low, in this case below 0.90, the likelihood of MACE is almost 2 to 3 times as high as compared to cases in which the post-PCI MUFR was above 0.9, in which the event rate was merely 2.7% at 3 years. Subgroup analysis in this trial, no clear heterogeneity. And then finally, to conclude, 2 studies I wanted to highlight, because these are very important trials that will pop up on your radar very likely within the next year or so. One is the FAVOR4 QVAS trial, which is a randomized control trial that will assess the use of QFR to guide vascularization strategy in patients that are in need of valve surgery, but also concomitant CABG. So in those patients, surgical grafting will be determined based on a QFR guided strategy in arm 1 of the trial versus a angio guided strategy in arm 2 of the trial. So almost so a bit more than 700 patients will be randomized with a primary endpoint of death, MI, stroke, unplanned revasc, new renal failure, or a new need for dialysis. So this trial is ongoing, and we hope to be able to see the results somewhere in the course of next year. Finally, this is a trial that we were trying to pursue already for 2 years, but I'm pleased to see that our Chinese colleagues did manage to set up the trial, which is obviously a challenging one. This is the FAVOR5 AMI trial, a multi-center prospective blinded sham-controlled trial that was set up to test whether non-culprit lesion revascularization in patients with STEMI based on a QFR and RWS guided strategy would result in superior results as compared to a standard approach being a angio guided revascularization strategy of all non-culprit lesions with a visual diameter stenosis of above 70%. So obviously a trial that was challenged, at least in Europe, by the need for very high number of patients to be enrolled because of the estimated relatively low event rates. But here, indeed, the sample size appeared to be 5,000 patients, and those are currently being randomized in China for a primary endpoint being major cardiovascular events as a composite at 1 year, if I'm correct. So with that, the final trial I wanted to highlight and conclude with a final slide on the newest kit on the block, that is CT-based MUFR. Professor Tu already highlighted it, that this algorithm is not just applicable to angiography, but also to OCT and IVUS images, as well as to CT. This is the software package that has been recently released and is currently being commercialized, in which in basically less than 2 minutes, completely AI-based and using the validated flow algorithms from Pulse Medical, you can get a complete reconstruction of the complete coronary artery tree with a QFR or MUFR in each of the individual vessels, completely automatically annotated, including side branches, myocardial mass, plaque recognition, and physiology available in less than 2 minutes. In case the CT quality is accurate. That was recently tested now in press and radiology, showing that this algorithm is actually very accurate once tested against SPECT and PET-CT up to 5 years using the basic assessment as a reference. So with that, I want to conclude in showing you a slide of the final guidelines that actually just recognize the use of QFR as a potential valuable alternative to FFR or IFR to guide clinical revascularization if there is a lack of ischemia detection upfront in patients presenting with stable or unstable disease. Now with a level of recommendation 1B in the just released guidelines for chronic coronary syndrome in Europe, based on the complete set of favor trials that have emerged in the past decade. So with that, I would like to conclude and thank you for your attention.
Okay, thank you, Dr. Jost, and thanks for sharing this important clinical evidence. And we know that when the new technology is released in the clinical, people are always curious about the accuracy. And also we know that the more important thing is that whether this technology can provide improvement of the outcome. This is, I think, is more important for the patients. And also we're glad that based on the Phase 3 China, Phase 2 China, Phase 2 Europe, Japan, the QFR or angio-based FFR technology is also recommended by the guideline, I think last 2 weeks from the ESC. And also we see there are some questions from the chat box. The first is about what will be the impact of the guideline change on the use of QFR or MUFR in Europe?
Yeah, this is a tremendously important question. As you know, there's always a cascade in which new technologies are being introduced in clinical practice. Step number 1 is the clinical validation. Step number 2 is the outcome trial. Step number 4 is the guideline adoption, and then step number 5 obviously is reimbursement. And that's the stage where we are in Europe at the moment. Physiology is reimbursed in most of the countries in Europe. Although changes are constantly happening, for instance, in France now, the reimbursement for physiology has been substantially reduced. And that puts the use of angio-based physiology in a different daylight, because negotiations need to happen in a way that we need to decide as a community and as payers per individual country how we want this technology to be adopted and how we want it to be reimbursed. Because obviously there are specific DRGs in some countries in which it is embedded. In some countries, the use of a pressure wire or an invasive technology results in a particular reimbursement. But in this case, we're talking about software. And software can be distributed based on license models, price per click models. And that is something that our Chinese colleagues already have a lot of experience in. But in Europe, it's something that, at least for physiology, is not yet happening at the moment. And those are discussions that need to take place per country, and are also discussions that need to take place per hospital, because obviously buying a catheter is practically relatively easy. You buy a catheter and you can use it in routine practice, but buying software needs to go through different cascades in the hospital. It needs to be approved by the local IT, etc. So that may pose some challenges. But I think all of these will be overcome in the next year or a couple of years, and I'm very confident that these technologies will start to become extremely important in clinical day-to-day decision making, simply because they're much more easily applicable in routine practice as compared to conventional pressure wires, once properly embedded in your routine practice. So more to come, but absolutely more discussions need to follow with payers and individual institutions.
Okay, thanks, Dr. Jost. And another question from Eduardo. So compare with angio FFR, what's the advantage of CT-based FFR?
So that's a good question. Obviously, both rely on the same conceptual, on the same concept, so to say. So at the end, as Professor Tu nicely elaborated on, in order to computate image-based physiology, you need several entities. One is a 3D or a reconstruction of the artery of interest. 2 is the flow model, and 3 is the inlet boundary condition. Well, assuming that the reconstruction of the segment of interest can be done by either angio or CT or, for instance, OCT or IVUS, the conceptual difference is actually not there because it's all based on the same three basic concepts. So I would say there's little difference in the use of angio versus CT or OCT based physiology. They all prove to correlate very well to conventional pressure wire based physiology. So from that perspective, they're more or less comparable. Perhaps the more important question is, how would you position the use of each of these technologies in routine practice? And I think that's a different discussion. My perspective, obviously, in a patient that presents with a STEMI and a non-culprit lesion, there's little discussion as to that, as to whether CT is perhaps not the most appealing alternative. In a low-risk patient that comes with stable CCS class 2 angina, a likely potential best first step could be to perform a CT scan. Non-invasive, patient-friendly, readily available in each institution. And now with this software, you can have this technology readily available on site without the need to ship your images to HeartFlow in the US to wait one day to get the results. So there are potential differences and potential advantages with this technology that I think have a great potential in routine practice.
Thanks for sharing. And I think another similar question. So can we use only IVUS and the UFR to guide the PCI with less radiation from the angiography?
Yeah, that's an interesting question. As you know, as many of you know, I'm a big proponent of intravascular imaging and IVUS in particular. So there are a lot of advantages of using imaging, and one is that, for instance, specifically related to IVUS, you can significantly reduce the use of contrast and perhaps also somewhat radiation. But at least contrast. And if you would base your physiological examination on the 3D reconstruction you make from the IVUS or the OCT, if you may, that could help. Whether that truly reduces radiation, I'm not so sure. Whether it reduces contrast is something that is certain. So I think also this technology is appealing, although it needs to be said that the most widely tested platform obviously is the QFR/MUFR platform. The CT-based platform is also in a far-fetched stadium in terms of now even being commercialized. The UFR platform is tested in several models, but is perhaps the least less mature technology, at least to be implemented in routine practice. So it has potential, but yeah, maybe Professor Tu or you can highlight on the fact that Pulse is working on a combined IVUS system with fully integrated angio and IVUS-based physiology and a IVUS catheter from the same company, that it gives you the best of both worlds. So this could be something to look out for within the next 1 to 2 years.
Thank you, Jos, for the comment. Indeed, I agree with you that the diffuse fluid technology and the most widely validated is the MUFR or the QFR, and the other one is the CT, and let's say the UFR is using in less validation study as compared to the other two. And the main reason is that if you perform IVUS and also FR in the same patient, you don't find that many patients have two perform. So it's difficult to find the data with both IVUS and FR, at least in China. And second is that if you really use clinically or online, and really need to have the UFR software inside the console, otherwise to transfer the data, imaging data from the console from other vendors is going to be difficult. For example, Boston Scientific console, they need to close the patient in order to be able to start transferring, and that's end of the procedure. So it's difficult to do it online or in real time. So now we have the UFR directly in the console that make it much easier. So perhaps we'll see more and more evidence in the coming years to come.
Yeah, thank you, Professor Tu. And I think also maybe you can have some answer for the question from Professor William Weiss. So how come CT MUFR can be done in no time versus the 24 hours or more longer process needed from the heart flow physiology by CT?
Good question. So the fundamental difference, I think, is that the CT MUFR is using the MUFR algorithm based on simplified fluid dynamic equation. So it does not need to, like half flow did, do a meshing and then using supercomputer to compute the flow at every small mesh there. So in that way that it can be performed very quickly, as I demonstrated in the MUFR software just in my presentation. So these are the biggest difference. Second is that second fundamental difference with the half flow solution is that I think half flow is using the segmentation of the myocardial mass to estimate the flow, while we are using the lumen to reconstruct the healthy lumen to estimate the flow. So we do not need to do the mass segmentation. Thank you.
Thank you. Thanks, Professor Tu. And so I think we can move to the last topics. So welcome Dr. Chen Guangli from Zhongshan Hospital, Fudan University, to give us the last presentation with the title of Prognostic Implication of Angiographically Derived Radial Wall Stream for Lesion Progress and Acute MI. So Dr. Li, please.
Okay, thank you, and good afternoon, Professor Wines, Professor Tu, and Professor Jones, and everyone online. And today I will show this topic about the RWS, and I'm Dr. Chen Guangli from Zhongshan Hospital, from Shanghai, and this is my disclosure. And as we can get the information from Professor Weiss and Professor Tu. We can get the QFR or WMFR from the angiography, and also we can get the RWS. We can call the ratio wall stream to at the same time from the angiography to decide the vulnerable plaque, and we can get the both information from the angiography. And I will show the angiography from one case, and this is a case example from our center. And this is a 86 years old male patient diagnosed with stable angina and at index procedure. And from here we can see this is the angiography about the LAD, and this is the angiography about the circumflex, and also the angiography about the RCA. We can see this is mild lesion located at the RCA, and also the mild LAD, and also we can see a very tiny stenosis at the middle segment of the circumflex, and this patient has a history of hypertension and with no history of diabetes, and also the hyperlipidemia. And from this angiography, also we didn't perform the PCI, and the standard secondary preventive treatment for CAD was given for this old patient. But unfortunately, and about 27 months later, this patient suffered a non-STEMI, and from this angiography we can see a subtotal lesion at the Parks RCA with fast progression. From just 2 years ago, we can see a very severe stenosis at the Parks RCA, and also we performed the PCI on RCA, and we implanted a 3.5 by 38 millimeter DS in mid to Parks RCA. But however, unfortunately, slow reflow happened after DS implanted, and which revealed a vulnerable plug in the middle of this RCA, and also we gave some nitro, and also final angio shows TIMI2 grade, but from this angiography we can see very fast progression for this patient at the RCA, and if we look back for this case, we do the QFR and RWS analysis for this patient. If we see the RCA, we can see this μFR shows 0.88 at the index procedure, and the QC showed diameter stenosis was about 37%. And if we see the follow-up angiography, of course, this is a subtotal occlusion, and the μFR, of course, is very, very low. But if we do analysis for this patient about the index procedure RCA, we could see the RWS maximum was about 14%. And also, if we do the analysis for the circumflex, we can see the μFR was also okay, and 0.95, and the diameter stenosis was about 23%. And if we do analysis for the follow-up angiography, we could see the diameter stenosis was about 48%, and we could see this circumflex is also a fast progression for these lesions. And we do the analysis for the RWS was about 14%, just as the same as the RC. And also we could see another vessel LAD, and also the μFR is okay as the index procedure, and also the diameter stenosis was about 40%. And if we see the follow-up angiography, the angiography said we could see the same stenosis at the follow-up angiography, and the diameter stenosis was about the same, just as the index procedure is about around the 40%. And if we do the analysis for the RWS maximum for the RAD was about 12.6%. So from this case, we could see just one patient and a different vessel and different results for the follow-up in the angiography. And for the RCA, we could see a non-STEMI target lesion just at the RCA, and also we could see a fast progression for the circumflex. But for the LAD, we could see just the stenosis was stay the same. So maybe the RWS will show the different results. So this is just one case. If we look back to for the some cases, and if we do the analysis for the cohort, we could see from this analysis a post hoc analysis in a study cohort, including more than 600 patients with more than 800 intermediate coronary lesions identified as the index procedure with angiographic follow-up of up 2 years. And from this study, we could see the patients with at least over one de novo and untreated non-correlated lesions at the index angiography, and with repeat angiography performed during a follow-up of up to 2 years will be included. And we could see the this lesion will defined as 30 to 70% diameter stenosis by visual estimation, and the angiographic lesion progression was defined as over 20% increase in diameter percent and within the same stenotic segment during follow-up. And from this study, we could see from the more than 6 patients with more than 800 intermediate lesions, we could see the maximum value of the RWS over 12% will suggest progression for these lesions in 2 years. And this is another case from our hospital, and we could see this is a very young patient, a 48 years old male patient was diagnosed with unstable angina at the index procedure, and also we could see a mild lesion with a percent diameter stenosis of 31% located at the middle segment of the LVD was identified. And after about more than 2 years, we could see a acute STEMI occurred, and which could be clearly attributed to having arisen from the target lesion. According to the angiogram of the predilation, we could see for this patient the maximum of the RWS was also the more than 12%, and this value is about 14%. And so this is the case from just from our study from our hospital, and we just do the analysis for the patients in our hospital, and we find about 3,000 mild to intermediate lesions in these patients, and assessed for RWS analysis, and at last we could get about 2,000 lesions in about 2,000 patients for this analysis, and from this cohort we could get a AMI group about 44 patients, and also we get 1 versus 3 propensity score matching study for this AMI group, and we get a control group, and finally we get a control group including 132 patients, and from this study we could see the lesion length and also the maximum of the RWS will predict the AMI, and we could see from the AMI group and also the control group we can see maybe a significant difference from the AMI group to control group in the lesion length and also the maximum of RWS and also the lumen diameter changes. And from here we could see also the AOC analysis shows the AOC area was about 0.83, and also the lesion length was about the AOC area is about 0.60, and from here we can see in this AMI group also we can see the RWS maximum value above the 12% was higher than the control group. And from here we can see if we do the analysis between the AMI group to the control group, we could see the maximum of the RWS above the 12% is a very significant risk factors for the AMI, and so this is just a small study from our hospital, and I think maybe from this study we could see the RWS just derived from the angiography was associated with an increased risk of stenotic progression and subsequent MI events in just the intermediate lesions. And maybe this just a very simple analysis for RWS is expected to be a feasible adjunct to assist risk stratification of angiographically mild to intermediate lesions in clinical trials. And we think maybe in the future, the favorable results of the preliminary study may warrant further investigation in future prospective trials. And we think from maybe in China and also in Europe and in other countries, maybe we will have more and more large cohort to show this value of this very simple technique, and we will use this technique to predict the vulnerable plaque, and maybe we will use this technique to do just as a study, as a previous clinical trials. We could see if we will predict the vulnerable plaque, and we will do some maybe drugs, maybe the PCI, and to prevent the risk of this vulnerable plaque. And we will believe maybe as a progress of the technique, and we will have more and more I think maybe just as drugs and the PCI, maybe we can to prevent the MACE for this high risk population. And this is the topic about the RWS, and thanks for everyone.
Yeah, thanks, Dr. Lee. Thanks for sharing about the technology of RWS. And also, we know it's very late in China, and you just come back home from the hospital. So thank you first. And also, we see that Professor William Weiss have one question. For RWS, you need excellent angiograph quality. So what's the percentage of the analyzable angios when doing the retrospective analysis for RWS? Hello, Dr. Lee.
Yeah. I'm sorry, I'm muted. And yes, this topic we have talked with Professor Tu, and just from the data from our hospital, and for now we use very low, maybe about 7.5 FPS for the angiography, but this this angiography is not so good as just the angiography maybe 5 or 10 years ago, and maybe 5 years ago we use about 15, sometimes maybe the 13 FPS and angiography, and this angiography is more feasible for the analysis for the RWS. And so I agree with Professor Weiss, and I think maybe the quality of the angiography is very important for the analysis of RWS. And also I think maybe for the IMR, angio-IMR was a QFR, maybe a good angiography is needed.
Thank you, Dr. Lee. And also, I see that maybe Professor Tu, you can also share your comments about the requirements for RWS.
We can put some add additional comment there. Indeed, I think we have seen that in some sites in China, as Dr. Lin just mentioned, that they changed the frame rate of the angio system to 7.5. So this is not enough, not sufficient for radial wall strength analysis. So the minimum requirement for radial wall strength we recommend is 15 frames per second. So if you want to use that one, decree that I think the angio need to be acquired at 15 frames per second. And the other requirement, I think, is the good contrast feeling is important. So you need to at least inject the contrast slightly longer than when the contrast reach to the distal position. So you need to have a feeling of the contrast for entire cardiac cycle after reaching the distal position. So these are the two requirements.
Okay, thank you, Professor Tu. And also another question from Eduardo. So what's the difference between RWS and wall shear stress?
Maybe I can answer this technical question. So indeed, the wall shear stress is like I explained it slightly at least one before that is induced by the fluid. So it's actually is because the blood flow induce the stress tensile position at the wall. So and the radial wall strength is the strength of the wall, the vessel wall cell. So it's actually the interaction between the blood pressure, cardiac contraction, and the plaque composition. So these two are quite different. So wall shear stress, I think, is important in the initialization of the plaque and slow progression of the plaque. I don't think it's going to be important in the fast progression or rupture of the plaque because the magnitude is too small. And the vice versa, the radial wall strength or the wall stress, plaque stress, some people call it plaque stress, is more the factor that behind the plaque rupture. So it's causing fast progression and also plaque rupture.
Okay, and I think another question from Wendy. So can I use RWS for the culprit vessel, or there are any cases that RWS is not recommended?
Good question. So for culprit vessel, apparently is more complex because the lumen geometry at the stenotic at the rupture at the culprit side is more complex. We have not done validation in that subset, so maybe it will be interesting to investigate in the future. And the other one is when you have a myocardial bridge. So if you have myocardial bridge, the lumen contour is changing over the cardiac cycle. So you will get a high radial wall strength as well if you analyze the vessel with the myocardial bridge.
Okay, and I think Professor William once also comments about why we should use 15 frames per second because it's need 4 or 5 images that analyze during a single cardiac cycle with the optimized contrast feeling. So that's why I think just like Professor Tu said, we need the higher frame rate and also the good contrast feeling. And also question from Professor William Weiss. So where does SWS fit? Did you abandon it?
Sorry, I did not get the question. So where does SWS fit? Professor Vine, maybe you can illustrate. Oh, SWS. Sorry. So he bring we developed another technology called superficial wall strength a few years ago that using two projection to reconstruct the 3D and at different cardiac phase we calculate the superficial wall strength. And we found out that it's very difficult to implement it in practice. It can be analyzed in the collab with a sophisticated analyst trained by a lot of training to certify the analyst to do that, because you need to make sure that the reconstruction, the matching of the two projection is perfect. If you have some mismatch there, then this will create some artificial, let's say, it creates some error there, and the error will compromise the radial wall strength or the strength analysis. So in the end, we found that it's too difficult to use the superficial wall strength in practice. So it will stay in the lab. I don't think it's going to be used in practice.
Yeah, and I think Dr. Lee has some question for Professor William-Weiss. So what do you think of the PREVENT trial?
Yeah, of course. I think it is the first trial that really is showing light in at the end of the tunnel in trying to improve outcomes and reduce acute coronary syndromes with some sort of intervention. There have been many attempts in the past, many devices have been tested, but no trial really has shown that preventive PCI can be useful. So it's one trial. It has this interesting analysis that the follow-up data are shown and updated every meeting almost, but the primary endpoint short term is already positive. So it requires intracoronary imaging. And again, it's not about image-based against intracoronary imaging. I think the advantage of image-based is that it's there. You have the angiogram. So why would you not use that information, including RWS, if it's further validated prospectively, which is ongoing? So, the trials have to be, to be designed after this should incorporate this angio-based information. And let's see whether it's sufficient or whether you want to qualify or introduce intracoronary imaging on top of it to be more precise in the individual patient. So let's not take the route again of looking at opposing trials, one technology against the other. This technology is available, and I insist, it is available across the world, or it has the potential to be available for anyone on Earth. When, large parts of the world are crying for access to care. So denying this would be really, it's our social responsibility, I would say, that we push this forward and make it available and use it for what it can do. It's not going to be the answer to all questions, but because it's there, we should use it.
Okay, thanks, Professor William-Weiss. And I think this is all the question in the chat box. And also I think that the time is here. And so first, thanks everyone to give very interesting topics. Thanks Professor Weiss, Professor Tu, Dr. Jost, and Dr. Lee. And also thanks for all the people that attended today's meeting. So at this moment, we still have 60 people in the meeting room, and also most of the time we have over 120. So thanks everyone for joining today's meeting, and have a good night. So thank you everybody. And also, if you have any request or about the technology, welcome to follow us on the linking, and also leave your message to our website or email. Thanks everyone.
Thank you all. Thank you all for your attention.
Bye-bye.
Bye.